Hello everybody, buonasera a tutti. My name is Dr. Reisaki and it is a pleasure and an honor to be here to discuss pediatric emergency radiology with you. As you can understand, the topic is enormous. There are major textbooks on this field. What I've chosen to do in the next 30 minutes is to discuss 10 situations of a please do not miss diagnosis in pediatric patients that are encountered exclusively or almost exclusively in children and are related to patients' health. The first situation comes with this vague history of an 8-year-old female that fainted following playing at the playground and suffered from respiratory arrest, intubated, and this is her MRI scan that is unremarkable, and this is the spinal MRI scan. You can see the artifact, the known artifact, coursing obliquely from the fourth ventricle to the anterior spinal cord, but then it's quite prominent, and here it's a little bit bulky. And on axial views, you can see that there are minute hyperintensities that are more prominent than the expected gray matter of the spinal cord. The child, upon extubation, could not move the arms and legs, and this is her follow-up MRI 3 days later, and you can appreciate extensive medullary edema extending into the lower medullary conus, exhibiting the typical cobra head sign at the transverse scans. Scivora is most often encountered in children, the etiology being increased elasticity of the cervical spine. It's usually at that area and less commonly in the thoracic area, and can present with a wide spectrum of neurological dysfunction ranging from complete transection to minor cord concussion. Your X-rays and your CTs will be normal, and the pathogenesis is extreme extension or flexion or distraction of the spinal column. So beware of trampolines and bouncing castles when there are many children of different weights, because the big-sized children will actually produce the smaller children to bounce off and injure their spines. And the cobra head sign is encountered in a spinal cord ischemia, and this explains the distribution of the changes. Post-traumatic ischemia in our patients, you have lower medullary involvement due to branching vessels coming off the upper anterior cervical artery, spinal artery, and then you have ischemia of the deep branches, which explains the typical location on axial scans. Moving further to the thoracic area, this is a typical X-ray of a typical situation, and if you've seen it once, you know the diagnosis. If you don't, you need to work through this. This is mediastinal shift, this is compression, atelectasis of the left lower lobe, overexpansion of the left upper lobe extending to the right of the midline. And if you don't know that this is a congenital lobar emphysema, then you need to think as a clinician of the medical and surgical etiologies of neonatal respiratory distress, and then you have imaging clues like a loosened hemithorax with a mediastinal shift. Few diseases can do that apart from the CLE that we saw. Consider diaphragmatic hernia when you see this bubbly appearance of the lung with few gas in the gastrointestinal tract in the abdomen. When you see this bubbly appearance with a mediastinal shift, think of congenital cystic adenomatoid malformation. Know the differences of air leaks between adults and children. Despite the typical appearances known in adults, consider the sharp heart sign or a crescent-like lucency by the heart in patients that are X-rayed supine. Pneumomediastinum in children does not appear as small air collections around the central tracheobronchial tree or esophagus. They are big chunks of lucencies of air that are situated between the heart and the elevated thymus, causing the inverted V sign or the angel wings sign or the known continuous hemidiaphragm sign. And there's another situation of an air leak in the interstitium of the lung, and this causes small lucencies with a tubular or spherical shape because gas dissects into the interstitial, the pulmonary interstitial emphysema. So congenital lobar emphysema together with cystic adenoma formation and diaphragmatic hernia can present as a radiopaque area that will shift your mediastinal structures to the contralateral side, and this will gradually resolve into a lucent hyperinflating area because amniotic fluid turns into air. And on CT scan, it will have this characteristic appearance, left upper lobe involvement of air trapping with splayed vessels, no cystic structures or bullae, right middle lobe involvement, right upper lobe involvement, and the clinical presentation may be very severe with severe respiratory distress requiring selective intubation of the contralateral side so that you can preserve some gas exchange or surgical removal of the affected lobe. If you have a choking episode, you are feared of a certain diagnosis. And when you have an X-ray like this, you need to decide which side is the abnormal side. And the answer is the side that has the abnormal vessels is the abnormal side. So if you have increased opacity, you look for consolidation. So you should lose the contour of your vessels, but here you can see vessels. On the other side, the vessels show pruning like an oligemic lung. So this is unilateral hyperlucent lung in children, and then you go through the differential diagnosis from Caffey's pediatric X-ray, and the top diagnosis is intrinsic blockage of the airway by a foreign body or a mucus plug in a lower respiratory tract infection. When your aspirated foreign body is radiopaque, then you can see it on X-rays and the diagnosis is easy. If it's not a radiopaque foreign body, which is the usual situation, then you try to look for consequences like consolidation, atelectasis, but occasionally your pulmonary parenchyma will be normal. Remember, in infants and young children, the size of the airways are small, so a small mucus plug or a small foreign body can block the airway completely or partially, and the symptoms may vary from acute death to a choking episode, and depending on the site where the foreign body is located. But if the choking episode is missed, then your child will be treated as a chronic bronchitis or asthma patient, or will present with destroyed lung. If you know the mechanism of obstruction, the foreign body is small, then it will allow for air to go through it on inspiration and expiration. You will have a two-way valve mechanism, and your parenchyma will be normal despite the presence of a foreign body. If the tubes on expiration are attached tightly along the foreign body, then your air will go into the parenchyma on inspiration, but will be blocked in a single wave of valve mechanism, and you will have focal air trapping with the splaying of the ribs, increased lucency, and an oligemic lung, while complete obstruction will cause atelectasis peripherally, left upper lobe, right lower lobe atelectasis. You should not be accused of missing a foreign body, aspirated foreign body on an inspiratory radiograph, because these can be negative in up to 50% of cases. So what you need to do, you need to actively exclude air trapping on expiratory radiographs, and if you cannot have a reliably expiratory radiograph, you need to position your patient on the decubitus side, and you know that the side that is closer to the ground with a horizontal beam and the child sitting on the one side should be the expiratory side. And you should be familiar with fluoroscopy and how the hemidiaphragms move during expiration. When do we do CT? We do CT when we have an increased suspicion of an aspirated foreign body, such as in this patient with recurrent pneumonias on the same location, and your first bronchoscopy is, or your radiographs are negative. You need to assess for complication, or where your pediatrician wants to exclude other pathology. Then your foreign bodies, even if non-radiopac on X-rays, might be radiopac on CT and can be seen together with destroying lung parenchyma. Moving below the hemidiaphragms, if you have a newborn with bilious vomiting, this one hasn't passed meconium, this one has passed meconium, your X-rays may show the diagnosis. You see distended gas-filled stomach, duodenum and jejunum, so nothing further. So this is ileal atresia, and this is not related to a trisomy. Like in a duodenal atresia, you don't need contrast study and the neonate goes straight to theater. Here, you don't know what is going on. There's no bowel dilatation, luminal dilatation. So what do you do next? You are thinking as a clinician. What do I have? I have vomit that is as green as spinach, and my differential diagnosis contains a do not miss midgut volvulus diagnosis. We must clarify that malrotation is not equal to volvulus. There are several subtypes, but the classical type of the duodenum lying to the right of the spine and the cecum of a high and medial position, this results in a short mesentery and has a propensity to volve. Therefore, past the immediate postnatal period, any duodenal obstruction should be considered midgut volvulus until proven otherwise. What do? We should be familiar with ultrasound and the normal relationship of this black dot, which is the superior mesenteric artery, and over that is the splenoportal axis, but further down this turns into the superior mesenteric vein, and this normal relationship of the vein being anterior and to the right of the artery is what we should see. If we see the vein anterior to the artery or to the left of the artery, then this occurs with malrotation. So if we see that, it's positive for malrotation. If we don't see that, this patient can still have malrotation. But if we see coma-shaped hypoechoic or anechoic structures around the superior mesenteric artery, we should put color. The fluid-filled bowel loops will not have color, but the vessels will produce this whirl sign seen on ultrasound and on CT, and this is very indicative of midgut volvulus. Occasionally, you will ultrasonographically see the proximal obstruction together around before the whirl sign. If your ultrasound is negative, then the test of choice is upper contrast study with a meticulous technique. What you need to do is you need to record the passage of the first bolus of contrast through the duodenal jejunal junction. And then your duodenum should climb up to the level of the gastric antrum and duodenal bulb and should lie to the level of the left pedicles of the spine or even further to the left. So if you can follow is that even into a redundant duodenum and on lateral views, then your duodenum will go downwards and then will climb upstairs and posterior to the descending duodenum. This is your normal expected position. If your duodenum does not go upstairs but remains downstairs and in relation to the left pedicles of the spine, it stays to the midline or further to the right, and if it has an abnormal course on lateral views, maybe anteriorly to the descending duodenum, this is very indicative of malrotation. Abnormally position of the jejunum on the right side is not necessarily an indication of malrotation, is not as indicative as the first two signs. These are all cases of midgut volvulus, some taken from the internet. So if you see a small bowel obstruction like a web or like a superior mesenteric artery syndrome, you don't know what's going on peripherally, you should consider midgut volvulus as well. And if you have an abnormal Z-like course of the duodenal jejunal junction, if your duodenum doesn't go up to the level of the gastric antrum, if you have this Z sign of mild proximal dilatation with an abnormal course of the DJ junction and further loss of the luminal diameter, and if your jejunum is to the right of the spine, consider malrotation with volvulus. The more specific sign is the corkscrew sign, indicating the course of the bowel lumen around the valved mesenteric root. The history tells the diagnosis, and everybody is familiar with the red currant jelly stool in a 2-year-old or less than 2-year-old child that can present with the meniscus sign of soft tissue mass surrounded by a meniscus-like lucency of the colonic bowel lumen, or the target sign of concentric lucent rings at the liver's aspect, being the trapped mesenteric fat inside the intussusception, or just small bowel obstruction. What I need to clarify is that if you find the typical ultrasonographic evidence on ultrasonography, which is the next test of choice in a child with the right age and at the course of the large bowel, this is most likely idiopathic ileocolic intussusception. If your finding is somewhere else around the abdomen and maybe the age doesn't fit, or maybe if it's a purpuric child or a child with cystic fibrosis, then you should measure your intussusception, because ileocolic intussusceptions are large and they are long. Compare this with the kidney. While ileoileal intussusceptions are managed differently, they can be managed conservatively, they can resolve spontaneously, and they measure less than 3.5 centimeters in all diameters. The other thing that I want to point out is that you should forget about the donut and the pseudokidney sign as being indicative but not specific for intussusception. They can be encountered in a lymphoma as well, and look for signs elegantly described by the POSO in radiographics, because now we have better machines and we can see the multiple concentric ring signs with bright lines representing the kissing serosa in different sides of the intussusception, or the crescent in donut sign of the trapped mesenteric fat inside the mass of the intussusception, or identification of small lymph nodes inside the intussusception. Use color Doppler, because lack of color Doppler together with trapped fluid in this intussusception are the O- findings of failed reduction, and look of the sandwich and hay fork signs when you scan the intussusception at a longitudinal section. A last point for intussusception is that the age should fit. If you are dealing with an infant of less than 3 months, or a child older than 2, or preferably older than 5 years old, think of a secondary cause, of an underlying cause. And this was the case in this 7 years old. We wanted to prove to the pediatric surgeon that this child potentially has a secondary intussusception. So together with the intussusception, we found a lot of trapped mesenteric nodes in and around the intussusception and a retroperitoneal nodes. These surgeons biopsied probably these nodes, and biopsy came back negative, and 2 months later this is lymphomatosis peritonei with a large lymphomatous, a small bowel mass, and a large retroperitoneal lymphomatous mass. Points to remember about abdominal pain in children. You need to consider age, because your differential diagnosis will be different with various ages, and it will be different in children with acute abdominal pain and chronic abdominal pain. Start with ultrasonography. You can usually finish with ultrasonography and x-rays, especially in neonates. Consider upper GI studies in suspected malrotation in atypical high obstruction cases, and low contrast studies in low or colonic obstruction, and reserve axial multiplanar imaging for difficult cases. Again, differential diagnosis will be different depending on age, with congenital etiologies predominating in neonates, intussusception, gastroenteritis, and appendicitis as the top 3 diagnoses in infants and toddlers. If you have a chronic abdominal pain, think constipation, and your second diagnosis is also constipation. Maybe your third diagnosis will be constipation, and consider renal pathology and genital pathology in older children. To conclude about abdominal emergencies in children, think as a clinician. Does the age fit? What do I expect at this age? Do I expect intussusception between 6 months and 2 years? Do I expect appendicitis as my diagnosis in a child older than 2 years? Think adult radiology in older children. Moving to the retroperitoneum, apart from acute pyelonephritis as an emergency, you have this situation. You have a newborn, few hours, bilateral antenatal hydronephrosis. You confirm bilateral antenatal hydronephrosis. You need to do your work properly and preferably start your renal ultrasound scan from the bladder and try to identify the urethra. And even if you don't identify the distended posterior urethra, you need to perform a Legge artis micturating cystourethrogram to exclude posterior urethral valves seen as a shelf-like filling defect between the dilated posterior urethra and the non-dilated anterior urethra. And remember that if your filling defect looks like a web, or if it's posteriorly further located at the middle of the posterior urethra, then this is anatomic variation. It's a diaphragm or a plica colliculi, as opposed to the shelf-like filling defect between the dilated posterior urethra and the anterior urethra with a poor lumen, together with evidence of diverticulation of the bladder and reflux. This is a very young patient, but this is a do not miss diagnosis. We know that following the diaphysis and the metaphysis, you have a loosened growth plate, and then you have your epiphysis, or your ossification center. And in here, by the tibia, the ossification center is displaced, and you have a ring of bone hanging off the expected site of zone of provisional calcification. This is the ring of bone, and you can see a second ring of bone by the fibula. So this is the classic metaphyseal lesions in child abuse, because these children can have corner fracture. These are around the arms and legs. They can be asymptomatic, often bilateral, very young children. This is a do not miss diagnosis. It depends on the angle of the X-ray, how you identify this bit of chip of bone off the metaphysis as a corner fracture or as a bucket handle fracture. And if you're not sure, you need to re-X-ray 3 weeks later. Your anatomic variations will stay unchanged, your fractures will heal, or a repeat X-ray might reveal periosteal reaction and might make the unnoticed first fracture evident. Why is it a non-miss diagnosis? Because this is a mechanism. The perpetrator shakes the baby, causing lateral, posterior, or anterior rib fractures, classic metaphyseal lesions, because the limbs are vigorously torted, and there are distracting forces. but you may have in a subsequent abusing event severe central nervous system injuries with subdural hematomas predominating, and the child may end up being severely injured, handicapped, or dead. So you need to protect children by identifying small, hyperdense subdural midline hematomas. Diagnosis is easier when you use a FLAIR MRI with multiple subdural hematomas of different ages. For those of you who do musculoskeletal ultrasound, hip ultrasound, you know that this is the normal aspect, the chondrossus junction, the synovial fold, the joint capsule, the labrum, the femoral head well contained within the os ilium. This is a dislocated hip with the displaced joint capsule and a lot of echogenic material inside the joint. And ultrasound echogenic material can be fat, can be blood, can be pus. So this is a real emergency of septic arthritis, because in the growing skeletal it can rapidly destroy the joint with significant morbidity, because the fibrinolytic enzymes from the irritated synovium can rapidly destroy cartilage. This is what you're looking for: fluid seen directly with ultrasound or MRI, and the irritated synovium seen as enhancement or as increased uptake with scintigraphy. On X-rays, we try to identify the classical signs of increased distance between the metaphysis and the internal aspect of the ischium, but also displaced fat pad, and we try on the lateral knee radiograph to identify fullness of the suprapatellar fat or effacement of the suprapatellar fat as opposed to the normal side. On ultrasound, your normal hip will have this echogenic line between the non-bulging synovium. That means that the synovial folds are kissing each other, and if there's fluid, then you will have anechoic fluid, or sometimes it will be echogenic, and you will have bulging of the capsule. Differential diagnosis is large, and even on MRI with an enhancing synovium, you cannot tell whether this is septic arthritis or not. This was toxic synovitis, and this was reactive arthritis due to underlying osteomyelitis. The only situation in which you can say this is definitely septic arthritis with MRI is fluid, synovial enhancement, together with soft tissue changes around it. And if you don't have fluid and your colleagues request a second ultrasound scan, do not say no, because you have a 5% chance of a false positive ultrasound for septic arthritis if symptoms are earlier than 1 day and if there's contralateral disease. Remember that osteomyelitis is hematogenous, so there is a specific site predilection. If you have an infant, then your hematogenous osteomyelitis might lodge against a growth plate at the metaphysis or through the transphyseal vessels into the epiphysis. And you might have epiphyseal osteomyelitis, you may have metaphyseal osteomyelitis as lucency, or with a disruption of the cortex with periosteal reaction. You can have rapid evolution into subperiosteal abscesses, as opposed to older children. They don't have transphyseal vessels, so they may have metaphyseal changes against the growth plate or against an apophysis, the metaphyseal equivalent site. Do not miss other diagnoses like trauma or tumor on X-rays. So here you have the classic site predilection for osteomyelitis against the growth plate, but this is bilateral in all bones, so this is leukemia, the classic appearance. And this hole in the bone is not against the growth plate or an apophysis, it's somewhere in the middle, so this is LCH. Remember that like in the abdomen, in the painful hip, the main diagnoses are age dependent. And I would like to leave you with this message. Do not be afraid of pediatric radiology cases. Do not postpone imaging in pediatric radiology cases. If we occupy ourselves with these cases, we will not be afraid to choose the imaging modality of choice, use proper technique depending on the indication. We should use ultrasound as often and as efficiently as possible. Think as a clinician, what's the symptom, what can it produce, is it the age appropriate? Take initiative, ask a pediatric radiology colleague or the internet for advice, and mostly importantly, you do not finish by giving a report on an ultrasound or on X-ray. You make sure in your heart and in your mind that the pediatrician gets the pediatric case, the pediatric orthopedic case, the oncologist, the relevant cases, and the pediatric surgeons gets to operate when appropriately. Thank you for your attention.